When using a compass, there are two things you need to know: magnetic north and your azimuth, which is the direction you need to go to reach your goal. In the United States, our political and moral compasses are off track, but it doesn't have to be that way. Come with me as I explore realistic options on how to improve our country. This is Off Azimuth. In 1950, a gallon of whole milk cost an average of 83 cents. By 1975, it was $1.57. By 2005, it had jumped to $3.20. And in 2026, the cost of a gallon of milk in the United States averaged $4.07. The steady increase in cost is commensurate with the Consumer Price Index, or CPI, which measures the change over time in prices paid by consumers for a representative basket of goods and services, such as food, energy, and housing. The CPI is maintained by the Bureau of Labor and Statistics. It tracks thousands of items monthly, and its results serve as a primary indicator of inflation. But consumer inflation is not standard across all businesses and platforms. In fact, there are very few similarities between consumer inflation and that of one of the biggest abusers of hyperinflation, the healthcare market. If the price of milk increased at the rate of healthcare inflation instead of the CPI, how much would it cost today? Healthcare inflation has consistently grown at a rate of 3 to 4 times that of consumer goods, meaning that instead of spending $4 on a gallon of milk, you'd be spending over $13. A pound of ground beef would be $10.49. A gallon of unleaded gas would be $12.20. And a pound of field-grown tomatoes would set you back over $8. A study from the American Medical Association found that from 1999 to 2024, family healthcare premiums increased by 342%. In 2024 alone, the health spending in the United States was more than $5.3 trillion, which represented the equivalent of 18% of the total gross domestic product. The United States often spends higher prices for the same brand name prescription drugs, hospital procedures, and physician care than similarly large and wealthy countries. That is due in large part to the fact that the United States system is a fee-for-service and largely voluntary, whereas most peer countries' health systems are compulsory. This allows the governments to better regulate the cost to the consumer, something not maintained within our nation. The Bureau of Economic Analysis data showed that the U.S. generally has shorter hospital stays and fewer physician visits per capita. A large part of the spending comes from higher prices rather than higher utilization. But that isn't the core of why we spend so much on healthcare. To understand how healthcare has grown so expensive, you must understand the 3 primary factors that have contributed to the exorbitant costs. The first is the growth of the healthcare insurance market. Second, the generally unregulated cost of pharmaceuticals. And finally, there is a shortage of transparency, which results in a lack of competition among hospitals. In the early 1900s, there were no federal requirements or support for medical cost coverage. It was a difficult time for healthcare in the United States, with debates raging between the value of socialized medicine versus individual or employer health insurance. It would be 1912 before President Teddy Roosevelt and the National Convention of Insurance Commissioners endorsed a social insurance program. However, even as traction grew for socialized medicine, the outbreak of World War I took priority, and proposed health legislation disappeared. In 1921, the Shepard-Towner Act passed, providing federal funds for prenatal and child health, which was one of the first federal health programs passed in the country. Unfortunately, by 1929, the act would expire without Congress reapproving any of its statutes. The Great Depression from 1929 to 1939 renewed interest in federally subsidized programs, including employment, retirement, and medical care. From that, the Social Security Act was passed in 1935, providing grants for maternity and child health. The 1940s became the decade for pushes towards universal health care. The Wagner-Murray-Dingle Bill in 1943 provided provisions for universal comprehensive health insurance, though it failed to receive a vote on the congressional floor. In 1944, President Franklin Roosevelt included adequate medical care as part of his State of the Union address. Toward the end of the decade, the National Health Assembly published a report calling for voluntary health insurance, but also stated a need for comprehensive universal coverage. Their efforts had a detractor, an organization actively campaigning against national health insurance, the American Medical Association. In 1948, the United Kingdom instituted their National Health Service Program, a healthcare system for all UK residents that was free at the point of use. As the American Medical Association reviewed the immediate effects of the NHS, they identified two key points that they believed would negatively impact the U.S. healthcare industry. First, they believed that a federalized program would result in anti-competition. Without active competition between healthcare systems or healthcare innovators, the medical infrastructure in the United States would stagnate. Secondly, however, the AMA pounced on a growing fear within the United States: communism. The AMA advertised that the NHS and any proposed legislation supporting a U.S. universal healthcare system as a socialist program. With the rise of McCarthyism from 1950 to 1954, where Senator McCarthy claimed that many in the federal government and Hollywood were secretly communist supporters, it wasn't difficult to sway public opinion against socialized medicine. With the success of the AMA's counter-protest, universal healthcare faded into obscurity. It would be revived occasionally through the decades that followed, but was always opposed by more conservative political representatives. Primary among them was Ronald Reagan. Before he was a politician or president, Ronald Reagan was a prolific actor, best known for 1940s and 1950s films, including King's Row, The Voice of the Turtle, and The Winning Team. In 1961, Reagan produced a 10-minute LP called Ronald Reagan Speaks Out Against Socialized Medicine. Believed to be financed by the AMA, the recording attacked current and former politicians who supported a move towards socialized medicine. In it, he warned that subsidized medicine would limit American freedom, and that, quote, "Pretty soon, your son won't decide when he's in school, where he will go, or what he will do for a living. He will wait for the government to tell him." He would go on in the recording to state that, quote, "One of the traditional methods of imposing statism or socialism on a people has been by way of medicine. It's very easy to disguise a medical program as a humanitarian project. Most people are a little reluctant to oppose anything that suggests medical care for people who possibly can't afford it." Providers, nurses, and hospital administrators sided with the AMA and Reagan's message. Less socialized medicine legislation was created, and none made it past committees to receive a vote on the congressional floor. As the battle for universal healthcare lost traction, the United States shifted its focus toward implementing and expanding individual and employer-provided health insurance. But the battle to provide health coverage for most U.S. citizens carried with it new complexities. Though the 1980s would see expansions in Medicaid payments to hospitals catering to low-income families, by 1987, over 31 million Americans, or 13% of the population, would be uninsured. The lack of insurance was blamed primarily on the cost of health insurance and the limitations placed by the insurance companies. companies could deny coverage for pre-existing conditions or could drop clients for chronic health issues. Premiums for employer-provided health insurance averaged $400 annually, compared to the average annual income at the time of only $19,000. Those health insurance costs reduced the size of wages and other fringe benefits. The cost became exacerbated when evaluating the cost of male versus female insurance. While nearly 70% of U.S. men enjoyed the $400 employer-provided health care, only 50% of women received coverage from their jobs, and costs could reach as high as $1,500 to $2,000 annually. This was attributed to expanding preventive measures like mammograms and pap smears, as well as reproductive health services. And all of these costs were the premiums paid to have insurance, not the out-of-pocket costs for copayments or deductibles. By 1997, the number of uninsured had increased to 42.4 million citizens, or 15.7% of the population. In 2007, the numbers hadn't improved, with approximately 45.6 million, or 15.3% uninsured. The largest improvement to healthcare in the modern era occurred on 23 March 2010 with the passing of the Patient Protection and Affordable Care Act. The largest reforms from the ACA were that all individuals had to acquire health insurance by 2014, a process facilitated by the creation of the healthcare.gov website, providing subsidies to assist low and mid-range income families who were ineligible for employer-provided plans, and eliminating the ability for insurance plans to deny coverage for any reason or to charge more due to health status or gender. The 2023 ACA open enrollment period saw an estimated 16 million people enrolled in health insurance coverage through healthcare.gov. Since 2020, uninsured rates have declined among adults from 14.5% in 2020 to 11% in 2023, and children from 6.4% in 2020 to 4.2% in 2023. Nearly 50% of the uninsured population is a result of those being eligible for marketplace subsidies or Medicaid, but not properly enrolling. But the ACA was far from perfect. While the ACA mandated medical insurance for the U.S. population, it did little to regulate how the health insurance companies complied with the law. Of the individual health insurance options provided by the healthcare.gov website, bronze plans average $495 a month, silver at $590, gold plans at $615, and top-tier platinum plans costing $1,166 per month. The average cost of purchased health insurance was $590 at the silver option level, which provided a good balance of premiums and deductibles. However, the $7,080 average annual cost of healthcare premiums did not include out-of-pocket expenses. In 2020, the average per capita healthcare expenditure was about $12,530. When evaluating family costs, those prices skyrocket. A Kaiser Family Foundation study showed that the average family health insurance plan in 2025 was $26,993, with employers providing just under $7,000 to offset the cost. Compared to the United States Census Bureau report that showed the median family income for 2024 was $108,600, it shows a significant portion of annual income being allocated to healthcare. Even when acquiring medical insurance, insurance companies still reserve the right to deny medical procedures or reimbursement. In 2023, about 19% of in-network claims submitted through healthcare.gov insurers were denied. That equates to nearly 49 million denied claims. Even Medicare Advantage averaged about 15.7% denial rate. Resubmissions of denied claims were cost ineffective, with administrative costs per denied claim increasing to $57.23 in 2023. Premier Inc. projected that providers spent $25.7 billion annually on claim adjudication. Even on appeal, 56% of the denials were upheld. For health systems, physician groups, and ambulatory practices, the denied claims delay cash flow. Providers must wait weeks or months for reimbursement, assuming their appeal is approved. For the nearly 56% that aren't, the denial leads to permanent revenue loss. Patients equally feel the impact. Insurance denials can delay care, increase the likelihood of unexpected bills, and create confusion about their coverage. Political division adds to the cost to the consumer. Beginning in 2010, the ACA provided subsidies to low and middle-income households to make monthly payments more affordable. In 2021, those subsidies were expanded to ensure coverage during the global pandemic. The American Rescue Plan Act of 2021 provided enhanced premium tax credits, credits that were extended by the Inflation Reduction Act of 2022. The enhancements included the removal of income cap for eligibility, which had previously denied the premium tax credits to households earning more than 400% of the federal poverty level. It also limited premium contributions to 8.5% of income, reducing how much enrollees paid for marketplace plans. The increased subsidies impacted nearly 90% of all plans purchased through healthcare.gov. The 2021 subsidies were set to expire at the end of 2025, and legislation to extend them failed to pass in Congress. With subsidies gone, Affordable Care Act premiums are expected to more than double for 2026, with the cost of some plans increasing from $888 a month to more than $1,900. The increased cost is expected to impact 22 million families across the United States. The unexpected expenditure forces families to decide whether or not to maintain their plan while reducing costs elsewhere, reduce their ACA plan, which lowers premiums but generally increases deductibles should they actually need to use their medical coverage, or drop health insurance altogether. In 2025, the CDC estimated that 11.6% of the population did not have health insurance, or approximately 40.3 million people. Due to the loss of enhanced subsidies, the number is expected to increase by 4.8 million people in 2026, resulting in nearly 13% of the U.S. citizens being uninsured. All of these bloated insurance costs drive up the healthcare inflation rate. But it's not insurance alone that affects the overall expenditure. 2015 exposed one of the greatest causes of healthcare cost increases, the unregulated pharmaceutical industry. In February of that year, Martin Shkreli, a former hedge fund manager, co-founded Turing Pharmaceuticals. Turing had a singular focus: to purchase off-patent medications. In August of 2015, they acquired the rights to Daraprim, an anti-parasitic medicine used to treat toxoplasmosis, which primarily affects immunocompromised patients. Since the patient population requiring the medication was small and drug inexpensive to make, there had never been a need to create a generic version, even though the patent had expired decades before. That month, Martin Shkreli increased the price of Daraprim 5,500%, from $13.50 per pill to over $700 per pill. The immediate result of the price increase was a reduction in access for patients who needed the medication, with many seeking alternatives or, in worst-case scenarios, going without the drug. The case of Martin Shkreli wasn't an isolated incident. In 2011, Gilead Sciences acquired Pharmasset, which had created Sovaldi, a hepatitis C medication. Though it costs between $130 to $350 per treatment to produce, Pharmasset had intended to market the drug regimen at $35,000 to cover their initial research and design investment. The intended price was staggering, since the treatment was offered in Egypt for $900 per course. Gilead, however, saw an opportunity to recoup their $11 billion purchase of Pharmasset in just 1 year. In 2014, they released Sovaldi with a cost of $84,000 per course of treatment. In a 2016 paper, Dr. Genevieve Halpenny evaluated the total cost of the inflated price tag. Since many patients suffering from hepatitis C qualify for Medicare, paying for Sovaldi treatments alone was expected to increase Medicare Part D spending by $3 to $6 billion annually. In 2016, drug manufacturer Mylan gained national headlines when it was revealed they had increased the price of EpiPens nearly 400% over the previous decade. One of the most egregious examples is insulin. In 1921, Frederick Banting, Charles Best, James Collip, and J.J.R. MacLeod were studying diabetes at the University of Toronto. Before insulin, the diagnosis of type 1 diabetes was a death sentence. Their team managed to isolate the medicine capable of controlling blood sugar. Initially, they filed a patent under their names, but transferred the patent to the University of Toronto. By transferring the patent, they intended to prevent any single entity from monopolizing the production of insulin. In turn, the university licensed the patent to pharmaceutical companies for a nominal fee, ensuring wide distribution of the life-saving medicine. However, as time progressed and the technology for producing large quantities of insulin improved, drug manufacturers were able to create new patents based off recombinant DNA technology. Currently, only 3 companies hold the patent to insulin: Eli Lilly, Novo Nordisk, and Sanofi. Despite insulin being more readily available now than it was in 1921, the cost of the drug has exploded. It reached its peak in 2019, averaging $541 for a 30-day supply. Though acts like the Inflation Reduction Act of 2022, which capped out-of-pocket insulin costs to $35 for a 30-day supply, have proven highly effective in managing the cost of vital medications, the United States has regularly taken a position of not limiting the production or cost of medications. In 2003, Congress passed the Medicare Modernization Act, which in it forbade the Health and Human Services Secretary from instituting any price structure on pharmaceuticals. In 2018, Food and Drug Administration Commissioner Scott Gottlieb stated, "The U.S. government doesn't play a role in drug pricing, but we do affect drug competition in terms of getting new drugs onto the market and create competition to older drugs, particularly with generic drugs." Efforts beyond legislation have been made to manage inflating pharmaceutical costs. The FDA evaluated and published a list of off-patent pharmaceuticals that had no generic counterparts. These were drugs that were primed for increased price hikes, like Daraprim, because the companies controlling the brand name production held an effective monopoly. The list sought to curb unwarranted price increases. But these efforts don't get to the heart of the issue. While inexcusable from a moral and ethical standpoint, what Turing Pharmaceuticals and Gilead Sciences did wasn't illegal. It's disingenuous to say that there aren't laws governing the pharmaceutical industry. It's just that the laws favor drug manufacturers to encourage research, development, and innovation. The Orphan Drug Act was passed in 1983. The law was passed to motivate drug producers to focus on rare diseases with patient populations of less than 200,000. Traditionally, these so-called orphan diseases were not a priority for pharmaceutical companies hoping to recoup billions of dollars invested in the creation and production of the drug. From 1973 to 1983, only 10 drugs were created and approved for these rare diseases. Since its passing in 1983, the Orphan Drug Act has led to over 600 new drugs being produced and distributed. To ensure the companies producing orphan drugs were protected from immediate competition, the Orphan Drug Act provided 7 years of market exclusivity. This exclusivity ensured that the FDA couldn't approve the same drug for the same condition for 7 years, providing time for the pharmaceutical company to cover their research and design costs. While the Act provided much-needed protections for drug manufacturers, it also enabled legally constructed monopoly power. The drug companies could charge whatever price they deemed necessary to cover their overhead costs. Other laws created extensive loopholes by which drug companies could legally increase drug prices. The Drug Price Competition and Patent Term Restoration Act of 1984 provided a 5-year exclusivity window to protect new chemical entities from generic competition. The Best Pharmaceuticals for Children Act of 2002 allows for 6 months of exclusivity for new medications targeting childhood illnesses. The loophole becomes a bottomless pit when you discover that the exclusivities provided by the Orphan Drug Act, the Hatch-Waxman Amendments, and the BPCA can stack, extending the period during which the drug is protected from generic competition. Drug manufacturing CEOs have repeatedly defended the practice of price gouging during the initial years of a drug's release. As recently as 2024, the Senate Help Committee questioned the CEOs from Johnson & Johnson, Merck, and BMS. They justified the initial high costs as a means to recoup their investment during the research and design phase. But a 2022 study published in the Journal of American Medical Association, or JAMA, reviewed the data from 60 new therapeutic agents approved by the FDA from 2009 to 2018 and found, quote, no association between estimated R&D investments and treatment costs based on its price at the launch of the product. The authors went on to say that without a defined correlation between investment and price to the consumer, then drug companies should make further data available to support their claims that high drug prices are needed to recover R&D investments if they are to continue to use this argument to justify high prices. As drug prices continue to rise, the cost to the medical system increases in like, leading to the healthcare inflation we've witnessed over the past decade. There is a final contributing factor to inflation: transparency. Keeping with the theme of transparency in healthcare, Robert J. Sawyer once said, "Secrecy was the problem, transparency the obvious cure." One of the greatest complaints about the United States healthcare system is a lack of transparency when it comes to medical billing. Consider this anecdote. If there are 2 gas stations across the street from one another, one charging $2.99 for a gallon of gas, and the other charging $2.98, it's more likely that the cheaper gas, even though only by 1 penny, will gain more of a market share. If the first gas station wants to compete, they need to reduce their costs to match or beat their competitor if they don't want to be pushed out of the market. In this example, competition controls price. When customers can shop around to find a better offer, then the overall cost across the spectrum is reduced or maintained. In the medical field, there is no such transparency. Emergency room patients don't know the cost of their treatment until they receive a bill. It's often unclear how much of the overall bill will be covered by their insurance, whether their deductible alone will cover the remainder, or even if the insurance company will deny their claim after the fact. Take childbirth as an example. The average cost of having a child in the United States is $18,865 as of 2025. For those with insurance, the cost is reduced on average by $16,011. However, the new family is expected to cover the additional $2,854. The price is higher for a cesarean section, with the out-of-pocket reaching $3,214. While those prices aren't ridiculously high, when a family's annual income is just over $100,000, a $3,000 bill can be financially straining. But childbirth isn't where the hospitals create the most hidden fees. Hospitals often operate on a thin profit margin for surgical cases alone. To make additional funds, they increase the cost of simple items like aspirin, a pair of gloves, tissues, Band-Aids, or sutures. These increased prices allow the hospital to cover overhead costs of facility maintenance, provider and nursing labor costs, and updated technology. What that looks like to the patient, however, is a $47 Band-Aid, $629 for a dose of ibuprofen, or between $500 to $2,500 for stitches in the emergency room, and that's with insurance. The lack of transparency can surprise patients following significant operations. Between 2003 and 2016, the price paid by large employer healthcare plans for inpatient full knee replacements increased by 74%, compared to a 28% increase in overall inflation. In 2023, Connecticut mother Kate Sulovsky revealed that after giving birth to triplets, all of whom required nearly 3-week stays in the NICU for observation and care, she was handed a bill of $1.7 million. She was charged $600,000 for one of her triplets who stayed 23 days in the NICU, and $500,000 apiece for the other two who each spent 20 days in the NICU. Her bill from the birth and hospital stay was approximately $100,000. Even accounting for good medical insurance, most insurance companies pay around 85% of the bill. In her case, she would have to shoulder $255,000 in costs. In 2026, the American Human Rights Initiative Foundation reported that 100 million Americans owed a cumulative $220 billion in medical debt. 41% of all U.S. adults currently have healthcare debt, with 14 million owing at least $1,000, and 3 million Americans owing over $10,000. In 2025, 66.5% of all bankruptcies in the United States were caused directly by medical expenses. The threat of medical debt is often enough to discourage patients from going to hospitals. In 2023, 36% of adults reported skipping or postponing medical care they needed due to the cost. One of the biggest offenders is ambulance transport. In 2022, 59.4% of ground ambulance rides were out of network, according to a Fair Health study. With the ambulance service considered out of network, healthcare insurance companies were not obligated to pay the fee, which reached between $940 for transport with basic services to $1,300 for a ride with advanced life support. It's no surprise that by 2024, nearly 25% of Americans chose not to call for an ambulance during a medical emergency. All these costs, drug prices, hidden fees, and insurance premiums, are significantly higher than any other high-income developed country, yet our health outcomes don't justify the price. In 2025, the Commonwealth Fund conducted a health outcomes comparison between the United States and 9 other high-income countries: Australia, Canada, France, Germany, the Netherlands, New Zealand, Sweden, Switzerland, and the United Kingdom. What the study showed was that the life expectancy in the United States was more than 4 years below the average of the 10 countries. Despite spending 18% of its GDP on healthcare, the U.S. had the highest rate of preventable and treatable deaths for all ages. It ranked last in access to care, 9th in administrative efficiency and equity, and last in cumulative health outcomes. With all this negativity surrounding our healthcare process, what can be done to improve our wellness and access to care? Transparency alone isn't enough to change our healthcare system. Our government must be willing to influence prices and moderate inflation without the cost being passed on to the consumer. Narendra Modi said, "While transparency reduces corruption, good governance goes beyond transparency in achieving openness." Openness means involving the stakeholders in decision-making process. Transparency is the right to information, while openness is the right to participate. The United States feels strongly about what is viewed as federal government overreach. But government influence is exactly what's needed to moderate the rapidly growing medical inflation. In 2008, the United States suffered through a financial recession. As fewer citizens were able to afford necessities during the financial downturn, many consumer arenas increased prices because of supply and demand. As there were fewer consumers, utility, grocery, healthcare, and transportation prices increased, thereby balancing the overall profit margins of the companies. All of this occurred without government intervention that could have managed the inflation. Compare that to Japan in 2009. A year after the U.S. financial recession, Japan experienced a similar financial crisis. Yet the Japanese government was quick to interject itself into the process. It implemented price controls on essential goods to prevent inflation. It provided subsidies to struggling industries to stabilize employment. And it strengthened regulations on financial institutions to prevent risky behavior. In terms of the U.S. medical inflation, more governmental oversight is needed to maintain or reduce the cost to the consumer. Insurance credits that expired in 2025 will cost 4.8 million Americans their health insurance. Congress had, and still has, the ability to effect change and reinstate that coverage. The biggest area in which the government could effect change is by managing and capping costs within the pharmaceutical industry. In 1987, Canada created the Patented Medicine Prices Review Board. The board determines a maximum price for individual drugs through a review process and negotiates voluntary compliance agreements with drug companies to ensure that manufacturer prices are within justification and are not excessive. The board evaluates the relative cost of Canadian drugs with 7 other countries. The result is drug prices that are significantly lower in Canada versus the United States. In 2026, Canada Pharmacy published a comparison list of prescription drug prices between the two nations. Though only a small sample of the total list, some examples include Eliquis, a medication used to lower the risk of stroke or blood clots in people with atrial fibrillation, which costs $813.65 in the US for 112 tablets, compared to $347.99 in Canada for the same product size. A Symbicort inhaler, used to treat asthma and COPD, costs $331.30 in the United States versus $75 in Canada. And since it was on the list, Viagra will set a U.S. patient back $733.20 for 12 tablets, while only costing $95.99 in Canada. Establishing a similar drug cost evaluation process in our federal government and putting a stop to the hyperinflation within the drug industry would go far to reduce healthcare inflation. If the United States wants to manage and reduce the exponential rate of healthcare inflation, there are 5 areas identified by the Baldwin Group that could impact medical expenditures. First is to apply legislation that manages the drug manufacturing industry. Aside from the high costs we discussed earlier, 2025 and 2026 have seen rises in GLP-1 usage. GLP-1 prices are extremely high, in large part because the medication is effective and popular. In the United States, about 12% of adults say they're already using one of the prescription brands. But because they are new medications, they are protected under the exclusion clauses of existing legislation. We are still a few years away from generic versions of the GLP-1 medications reaching the hospital formularies. While I don't endorse removing the exclusion protections, I do endorse the U.S. government managing and capping pharmaceutical costs like what's being done with the Canadian PMPRB. The second point is to expand and offer virtual alternatives for mental and behavioral health care. Beginning during the COVID pandemic, utilization of behavioral health services skyrocketed. Telehealth delivered behavioral health spiked 45-fold since 2020. The in- and outpatient clinics cannot keep up with demand, which requires the United States to finance alternatives. Increasing the health and human services expenses within the 2027 budget would allow the healthcare sector to explore increased virtual visits, digital tools, and embedding screening and treatment into more diverse medical departments, including diabetes, cardiac care, maternal care, and other chronic condition pathways. Furthermore, health insurance companies need to be incentivized to allow the pursuit of out-of-network mental and behavioral health care should in-network providers not have the bandwidth. Thirdly, along the lines of expanding virtual care in the mental health sector, United States healthcare needs to end its reliance on hospital visits and in-person appointments for general healthcare needs. The use of virtual tools reduces the overall workload on an already strained healthcare market, one that has struggled through understaffing and burnout of providers ever since the pandemic. Nurse advice lines, telehealth appointments, and virtual resources facilitate moving away from emergency room visits and encourage more urgent care, primary care, and virtual care appointments. The cost of hospital visits is one of the factors driving healthcare inflation. In 2025, the average cost of an infusion at a hospital was between $5,500 and $11,500. That same infusion was reduced to between $3,500 and $5,500 during primary care visits and those performed at infusion centers. The cost is reduced further by coordinating with in-home infusion care, where the cost dropped to between $1,700 and $3,500. Which leads us to point number 4. These costs are only known and shared because of transparency within the healthcare industry. Without transparency, then the cost to the patients is an unknown factor, and it becomes virtually impossible to reduce inflation. Healthcare clinics and hospitals must provide detailed data on cost drivers and procedure fees before treatment. In an ideal world, patients can pull up fee-for-service lists on hospital websites and compare costs so they're picking the most cost-efficient choice. The recent Consolidated Appropriations Act begins to tackle the need for transparency from the top down. Within the Act, there is a prescription drug reporting mandate that requires health plans and insurers to report drug costs and utilization data, report on the impact of drug rebates and discounts on premiums, provide data on prescription drug trends and price increases, and facilitate public access to the reported data. While the effects of the Act won't begin until the 2028 and 2029 years, it begins to chisel away at the stony exterior that has always hidden the invisible cost of healthcare. Finally, the United States needs to expand early intervention models. Our healthcare system can't be reactionary. It doesn't work if patients aren't seen until a serious problem arises, at which point the healthcare system must treat symptoms first instead of tackling the root cause. Screenings and early detections reduce the overall workload on hospitals and clinics by identifying problems and providing care earlier in a health crisis when the financial and labor costs are both significantly lower. Preventive medicine measures have been shown to greatly reduce long-term hospital care and healthcare costs. Even so, as of 2020, it was estimated that only 8% of Americans underwent routine preventive screenings. That's despite the statistics that show that preventive care can reduce healthcare costs by up to 30%, that regular screenings can lead to a 20 to 30% reduction in mortality rates for certain cancers, that vaccination programs have prevented 21 million hospitalizations and 732,000 deaths since 1994, or that chronic disease management through preventive measures can save an estimated $1.7 trillion annually. As the United States lags behind our developed nation peers in life expectancy, it's worth noting that preventive health behaviors can increase life expectancy by up to 10 years. Health insurance must prioritize preventive health measures in their annual care plans, which can be driven by updates to the healthcare.gov system. There are many avenues by which the United States can reduce the rate of healthcare inflation, whether through transparency, controlling drug costs, or increasing access to health insurance. But what is guaranteed is that if we don't start making changes, then the runaway healthcare inflation will eventually turn the U.S. into a nation of haves and have-nots, where only the wealthy have access to hospitals and top-rated care, while the poor and middle class live in overwhelming healthcare debt, all while suffering through a myriad of chronic health conditions. I look forward to a day where I can walk into an emergency room, pick up a menu of treatment options, all with clearly identified costs, and order my care like I'm selecting off an a la carte menu. That sounds like just the right amount of transparency. Thank you for tuning in.